Let's see an NCLEX tips and points video on COPD and asthma. This is a patient education regarding peak flow meter. How to use the peak flow meter by the patient, the instructions which needs to be given by the nurse. Before each use, make sure the sliding marker or arrow on the peak flow meter is at the bottom of the numbered scale, 0 or the lowest number on the scale. Stand up straight, remove gum or any food from your mouth, take a deep breath, put the mouthpiece of the peak flow meter into your mouth, close your lips tightly around the mouthpiece. Be sure to keep your tongue away from the mouthpiece. In one breath, blow out as hard and as quickly as possible. Blow a fast, hard blast rather than slowly blowing until you have emptied out nearly all of the air from your lungs. The force of the air coming out of your lungs causes the marker to move along the numbered line, not the number on a piece of paper. Repeat the entire routine 3 times. Record the highest of the 3 ratings. Do not calculate the average. This is very important. You cannot breathe out too much when using your peak flow meter, but you can breathe out too little. This is the reason why we will not calculate the average. Measure your peak flow at close to the same time each day. You and your healthcare provider can determine the best times. One suggestion is to measure your peak flow rate twice daily between 7 and 9 am and 6 and 8 pm. You may want to measure your peak flow rate before or after using your medicine, and some people measure peak flow both before and after taking medication. Try to do it at the same way each time. Keep a chart of your peak flow rates. Discuss the readings with your healthcare provider. Now let's see a comparison of COPD, which includes emphysema and bronchitis and asthma. Emphysema patients are also known as pink puffers, and bronchitis patients are known as blue blotters because of the physical appearance they are having. So let's see the comparison of the 3 conditions. First is regarding the risk factors. Emphysema, the risk factors are smoking history, occupational exposure, environmental exposure, alpha-1 antitrypsin deficiency. In bronchitis, smoking history, occupational exposure and environmental exposure are the risk factors. In asthma, smoking, family history of asthma, allergies, obesity or overweight, exposure to second-hand smoke. Health history we need to collect include in emphysema, exposure to second-hand smoking and smoke, exposure to second-hand smoke and smoking in bronchitis also, and in asthma, other than exposure to second-hand smoke and smoking, rhinitis and eczema you need to collect. The symptoms are slow, progressive and continuous in emphysema. It is slow, progressive and continuous in bronchitis also, but the symptoms are intermittent in asthma. Dyspnea is progressive on exertion in emphysema, progressive in bronchitis, and it is present during exacerbations in asthma. Sputum production is often present in emphysema. Bronchitis, it is present for at least 3 months for 2 consecutive years. And in asthma, it is present during exacerbations. Bronchospasms in emphysema, premature closing of the airways with air trapping happens. In bronchitis, obstruction by thick tenacious mucus, and in asthma, airflow obstruction by inflammation and mucus. Reversibility, emphysema it is non-reversible, bronchitis is also non-reversible, but asthma is reversible. Airway affected, alveoli are affected in emphysema, but in bronchitis and asthma, airways are affected. If a patient with COPD experiencing an exacerbation is on oxygen therapy, SpO2 and respiratory rate must be monitored continuously until the condition is stabilized. If the patient is receiving too much oxygen, it may blunt the respiratory drive. This point is very important. The respiratory effort in a patient with COPD is triggered by the decrease in oxygen, not an increase in carbon dioxide, which is different from the patient with healthy lungs. Therefore, too much oxygen and high partial pressure of oxygen and SpO2 may cause a decreased respiratory effort. So in COPD patients, we need to mind this thing. Hope you understood this video. Keep watching. Thank you.